So good morning, one and all. At the outset, I would like to thank Kumarvel sir for successive inviting me for this program and chairpersons Dr. Jyoti Prince and Anandi madam. So I'll be discussing regarding the lean PCOS, the myth or reality. That was the topic, and I'll be discussing regarding the diagnostic criteria and what is the definition of lean PCOS, pathophysiology, and what are the differences between the lean and obese PCOS, and what are the management options available. So this is the old and the previous criteria that was being used before 2023. That was a Rotterdam criteria, NIH and androgen excess society criteria. So almost the basic things are almost similar. The high androgens, polycystic ovaries, oligo or anovulations, maybe 2 out of 3 criteria that has been used. So with this background, so what is lean PCOS? So it is a form of PCOS that affect individuals with BMI of less than 25, meaning that they are not overweight or obese. So this is it is not a very standard definition from the guidelines. So non-obese or non-overweight PCOS are labeled as a lean PCOS. It doesn't mean that they should be underweight. So it is a normal BMI. This predominantly again from the Western. So in Indian cutoff it should be around 23. And so it contributes around 20 to 30% of the PCOS. That is 1/3 of the PCOS. So other well-known phenotypes are reproductive type and metabolic type. That is other known PCOS subtypes. So basically in reproductive type we have high LH and SHBG level with low insulin level, and the BMI may be a normal or low. That means that lean PCOS. And the classical one is a metabolic type that have obesity with insulin resistance. So with this background, there is a complex pathophysiology of PCOS. So there is no single drug or no single options is available for the management of PCOS, similar to what see in type 2 diabetes. So you can see that that is an individualized approach because the pathophysiology is entirely different. So there may be a genetics, epigenetics. That means that it includes the environmental, birth weight, and the environments, and ovarian dysfunctions, endocrine, neuroendocrine, and metabolic alterations. So there is a complex pathophysiology. So there is a different medical managements is available for the depend upon the pathophysiology. So whatever may be the pathophysiology, the consistent point is a ovarian pathology. That is a major element that is also contributing lean PCOS. So there is an imbalance between the androgens, AMH and FSH that cause a halt of the follicular growth or follicular arrest. So the high LH levels are required for the androgen synthesis. So it produces the high LH. It causes the ovarian theca cells produce most androgens. The most important androgens is androstenedione, that is from the ovary, and it is converted into testosterone in the ovarian theca cells. And insulin resistance, again, it is one of the major contributor or component of PCOS. So the ovarian pathology with the coexisting insulin resistance, that is a 2 major important pathophysiology similar to the type 2 diabetes, that is insulin resistance and beta cell dysfunctions. So here also almost similar, and remaining things are contributory to each other. So now we have moved into the 2023 guidelines. So the previous Rotterdam, NIH and the androgen excess society. So all the things now it has been not been used very commonly. So now we have moved into the consensus guidelines. It is from the 2023. So it is almost a reproductive society of American associations and endocrine society and European society. So all they come into the consensus, and these guidelines being used, and now almost more than 3 years. So basically this again the concept is almost similar. So either 2 of the 3 criteria. So one is the clinical or biochemical hyperandrogenism. So it is basically maybe a clinical diagnosis, and biochemistry may or may not be a very strong evidence. And second one is a ovulatory dysfunctions, maybe a clinical symptoms or maybe a follicle count. Or third one is a polycystic ovarian ultrasound and AMH. So this is the exclusion of other causes. So this is the 3 criteria, and out of 3 there should be a 2 for the diagnostic criteria. So again, predominantly it is a clinical diagnosis. Ultrasound may or may not be. Again, AMH may or may not be. And it is again very simple diagnostic criteria. And again, this one of the 2 important thing is the criteria they define is adolescent versus adult. So whenever the consistent feature is menstrual cycle high androgens, so that is similar. Whereas the ultrasound or AMH is not required for the diagnosis in a adolescent individual. So the adolescents hyperandrogenism and ovulatory dysfunctions, they are mainly required. Ultrasound and AMH is not recommended in adolescents, maybe around 12 to 18 years. So due to the poor specificity, that is a new update. So not to expect or not to interpret the ultrasound report or AMH report in a adolescent populations, whereas adult or 8 years after the menarche it is being standardized. So the most common or single irregular menstrual cycle definition is a more than 3 years post menarche to the perimenopause is less than 21 or more than 35 days, or the cycles of less than 8 per year. So this is consistent with whether lean PCOS or obese PCOS in almost all the subgroup of populations. So as already told that till 8 years after menarche, USG or AMH is not recommended in the diagnosis for individual. And ultrasonography, there is a follicle number per ovary, and many of the sonologists, they don't specifically mention these findings, but this is the consistent features and should be followed in the classical diagnostic criteria of PCOS. So the FNPO, follicle number per ovary, should be more than 20 in at least one ovary, and all the follicles should be a non-dominant follicle, because the non-dominant follicle is a major source of AMH. So whenever the more and more follicles, more and more AMH productions, and it is one of the biochemical correlations, the non-dominant follicle, the size should be 2 to 9 millimeters. So if it is more than 9, it should be a dominant follicle and is ready to become ovulate. So these are all evidence-based recommendations. So the strong evidences or RCTs are available, and other evidences are follicle number per ovary, follicle number per cross sections, or ovarian volume should be the other either. Ovarian volume of more than 10, it is being recommended. So as already told that the primordial, secondary and small antral follicles, there is a major source of AMH expressions, and there's a different assay methodology, you can expect more and more AMH. So AMH again, it should be it has to be in the normal or mid-normal range. So the too high AMH, too low AMH, both are not good for the ovarian marker result. So it's basically a test of ovarian reserve. So as already told, this the like U-shaped curve. So there should be a optimum level, too much level, too low level, both is not contributing to the ovarian health. So it has to be maintained. And again, AMH is the ovarian cells, it has been produced. So what is the proposed mechanisms of lean PCOS? As already told, 2 important components. One is the insulin resistance, and another one is the ovarian dysfunctions. So with this background of these 2 components, there is the pituitary has very important mechanisms. Again, that is the mechanisms from the KNDY neuron, that is a kisspeptin, neurokinin and dynorphin, that is because based on the hypothalamic level. So leading to the folliculogenesis arrest. So this is the symptoms, how to differentiate lean PCOS versus obese PCOS. So as already told that BMI is the cutoff criteria to differentiate lean versus PCOS, and you will be expecting normal or less than 25 BMI. Ideally, we need body fat percentage assessment by DEXA scan, other thing. BMI is again, it is not be a very good marker of to assess the obesity in a subgroup of Indian Asian phenotypes. So the prevalence is, as already told, 1/3. And pathogenesis, intrinsic ovarian dysfunction is a major important pathogenesis with neuroendocrine abnormalities. Whereas in obese PCOS, the pathogenesis is a insulin resistance, that is adiposity driven. And insulin resistance being there in the 2 entity, and so metformin may be useful in lean PCOS also, but the extent is subtle, where here is severe. And hyperinsulinemia again is mild and significant. LHFS ratio is a very important clue in lean PCOS, but in recent guidelines, this ratio has been removed. So we should not diagnose. So it is some predictions only, but it is not been a diagnostic criteria, the LHFS ratio. And androgen levels again may or may not be, and it is not be a very strong consistent things. So as already told that with intrinsic ovarian pathology, there is a lot of hypothalamic peptides, the kispeptin neurons in the infundibular nucleus called kispeptin neurokinin. So there is a lot of negative feedback from the ovary and hypothalamus. It secretes a lot of hormones. So it is a complex pathophysiology. So again, single drugs may not be very effective to address all these pathophysiological mechanisms. And two important things common here is a menstrual irregularities and infertility. So it is common in both lean PCOS as well as in the obese PCOS. And remaining things, clinical hyperandrogenism may be may or may not be there. One of the important thing is the lean PCOS is most of the times they don't come into the picture, or the diagnosis of lean PCOS, it is underdiagnosed because of the less awareness about the entity. So it is often missed or delayed as comparing with obese PCOS phenotypes. And coming to the management options of lean PCOS. So again, similar to the obese PCOS, there are various management options. The most importantly, lifestyle again here. And the other thing is a individualized approach based on the hirsutism is there. You use androgen receptor blocker like spironolactone or combined oral contraceptive pills, or in very refractory stages, finasteride also has been a role. And menstrual dysfunction again, combined OC pills, ethanyl estradiol plus progesterone combinations. Acne again, retinoic acids or antibiotics, and so infertility, I will be discussing some of the concepts. So the management options is almost similar, but some subtle changes in the lean versus obese PCOS. So coming to the diet and lifestyle modifications, as comparing with obese PCOS, calorie restrictions is not needed or unnecessary, since we should not aim to lose weight. So there should not be a calorie restrictions in case of lean PCOS, and they should maintain at ideal weight. And again, regular physical activity we have to encourage, and it improves the insulin resistance. And we have to encourage to consume vegetables and fruits. They are having adequate supply of minerals, vitamins, and nutrients. So it has to be a balanced approach, macronutrients and vitamins and minerals. So it has to be a time to emphasize all the things before initiating any medical managements. Coming to the metformin therapy. So the metformin treatment was associated with the improvement in the disordered menstrual cycles, maybe around 30 to 40%, even in underweight patients with the PCOS. And but there is no very strong evidences or consensus recommendations, and the guidelines still they not focus about lean PCOS. So we need more and more data regarding the how much dose to use or how long to use and what is the ideal benefit. So whatever studies are there, very small study, unrandomized study, and individualized experience, and that is the thing. So the metformin still it is lacking to prescribe metformin in PCOS. So in such situations, it is a clinician-based individualized approach, whether to use or not to use, and it's up to you and up to the patients, and we can start maybe a very low dose. And again, any drugs we have to wait for 3 months to get the optimum beneficial effect and pharmacokinetics effect. So it is an individual approach still for, and it is not been very consistent evidence is there to use metformin in PCOS, but definitely it has a role. And we have to low risk of hypo whenever the anorexia nervosa is there or poor appetite or intake is there. So we have to be careful and monitor the glucose also. And coming to the role of myoinositol, so the 3 gram per day myoinositol is appeared to have a positive effect on lean PCOS. And it important effect is it has improvement in the insulin resistance. So it improves the insulin resistance by acting as a messenger for the insulin signaling, and deleterious effect on the quality of oocytes at high doses. Again, it has to be balanced the dosage of myoinositol. Among the myoinositol, there are 2 myoinositol, is the D-chiro myoinositol and simple myoinositol. And here is one of our paper that was published in Clinical Endocrinology, but it was a obese phenotypes. It is from our Madurai Medical College and Government Rajaji Hospital, and RCT, and comparing the myoinositol with the metformin versus metformin monotherapy in polycystic ovary syndromes. And we did all the ratios, SHBG, free androgen index, and AMH, and it was one of the DM dissertations, DM student dissertation, and we could not find out any very significant improvement, but some of the subgroup of people, they have regularity of the menses that has been used, and more than the endocrinologies, it is been commonly used by the gynecological perspectives, and we are also now started using, not is a very robust way, but it has been some symptomatic benefit. So the addition of myoinositol to metformin exerts additional benefits in improving the cycles, regularity, and quality of life in PCOS. Questionnaire also is used. So how to position inositol in polycystic ovary syndromes? Again, this is the systematic review and meta-analysis in 2023. So some metabolic measures and potential benefits from the dichloroinositol for ovulation, but inositol may not have no effect on other outcomes, and no difference for the reproductive outcome. So from the guidelines, again, it is not a strong recommendations or consensus, or again want of RCTs. So the evidence supporting the use of inositol in the management is limited and inconclusive. Again, it is an individualized options. So comfortable and convenient, patient is happy, then you continue. So again, 3 months or 6 months you have to assess, and but it has to be optimal dose. Too much dose is not being beneficial and effective. It is a nutraceutical preparations, and it is coming under FSSDA under this thing. So the coming to the assisted reproductive technology in lean PCOS, and the lean PCOS exhibited a significantly greater rate of fertilization as comparing with overweight. So the ART perspective, lean PCOS, they are very well responder as comparing with obese PCOS. So again, we have to identify, then it's easy to make them to become pregnant in assisted reproductive technology. And again, significantly elevated fertilization rate with both GnRH agonist, leuprolide, and antagonist also. So the mechanism behind that is high success rate is the coexisting high LH in this lean PCOS. By giving the GnRH agonist, it reduces the LH drive. So it improves the quality of the ovulations or quality of the ovum ruptures and implantation potential. So definitely we should correctly identify the lean PCOS and use this technology so that the optimum beneficial effect is going to be better. And surgical techniques, and from the meta-analysis, bilateral versus unilateral was found to be associated with the comparable rates. So it has to be, there is no difference between, and it is obviously it is successful. So coming to the management options comparisons, so the lifestyle management, we have to make them fit metabolically, not by the weight loss, by lean PCOS. And diet approach, low glycemic index, balanced macros, macronutrients, and exercise again has to be encouraged. And metformin use, again selective, if insulin resistance and metabolic features are dominant, use it. So ovulation induction, letrozole or leuprolide, both can be used, and good response as comparing with the obese PCOS. And long-term risk, again, we need. So it gives a more area to work and emphasize about these lean PCOS. So the gaps in knowledge is among the methodological limitations, sample size were often too small to report significant results, and we need large-scale RCTs should be conducted and ascertain the significance, and specific age and ethnic groups with the syndrome should be investigated with the same diagnostic criteria to ensure the robust conclusions are needed. So the lean PCOS is not a mild variant, but a distinct metabolic and reproductive phenotype. So we have to appropriately identify, and we have to look into the how they behave, and entirely different from the obese or common garden PCOS. And again, if often remain undiagnosed until they encounter fertility problems as adults. And insulin resistance in PCOS is not entirely obesity dependent, hence it should be managed yearly and even in lean PCOS. So the management in lean PCOS is weight neutral and not weight focused. So with this summary and conclusions, I am concluding. Thanks for the kind attention and opportunities.